I'll begin with our Ebola response, and I'd like to do that by telling you a story. As you know, our agency began monitoring travelers who had arrived from the 3 Ebola-affected countries in late October of last year. And it was the Tuesday before Thanksgiving, late in the day. I confess I was thinking about the salted caramel chocolate pecan pie that I would be making to bring to Thanksgiving when I was notified by staff that they had contacted a newly arrived traveler, and this was their first contact with him. And when they reached him, he said, "I am so glad you called. I was just about to call 911. He had the symptoms of fever, vomiting, and diarrhea, which are all clinically associated with Ebola. And so what we did was we contacted the emergency medical services to arrange to have the patient picked up. We stayed on the line with him until they arrived. Then we contacted Unity Hospital, which is one of the 4 hospitals who had agreed to be a center for assessing and treating Ebola patients. And we let them know that they would be receiving a patient. Now, caring for a patient under investigation for Ebola is a huge commitment on the part of the hospital. Unity had to put their emergency room on divert in order to safely receive this patient. They had to establish a special route through their hospital so the patient could be safely transported to the intensive care isolation unit and not affect other patients. And they had invested hours and hours of staff time preparing and practicing putting on and taking off personal protective equipment. Once the patient was en route to the hospital, we at MDH sent a number of staff to Unity to provide technical assistance because caring for an Ebola patient is complex. Our laboratory staff assisted with specimen collection and packaging the specimen so it could be transported. The plan was that the specimen would be tested at the health department. At that time, we were one of 12 sites in the country that could do Ebola testing. We sent our medical director to the hospital to provide consultation, and infection prevention staff were there to make sure that the hospital staff were correctly using their personal protective equipment. And back at the health department, we were busy. We contacted the governor's office. We contacted the Centers for Disease Control as well as our local public health partners. We also prepared to interview the patient because we needed to know his activities and his contacts. We were preparing for the potential for a press conference in just a few hours. And then, because the emergency personnel had put on their personal protective equipment in the parking lot of the apartment building, many people had seen that. And so we needed to contact the apartment management and let them know that, you know, we were aware of what was happening and this did not pose a risk to their residents. And then we also worked with police to make sure that we had appropriately cordoned off the individual's apartment so that no one else could enter because of the potential for exposures. So this was all going on all evening, and it was 9:53 p.m., and in those stressful situations, you do remember the time very well. And that's when we got the call that the laboratory test was negative. While we weren't out of the woods yet, it was very good news. And the reason we weren't out of the woods is because you need to have a negative test after 72 hours of symptoms. And so this patient hadn't had symptoms for that long. So we tested the patient again on Wednesday, and it was thankfully negative. And then our laboratory staff were at the hospital at 7 a.m. on Thanksgiving Day to pick up the specimen so that they could test it right away that morning. And needless to say that when that specimen came back as negative, there were a large number of people who were truly thankful on Thanksgiving. If the test had been positive, it would have had a huge effect in terms of the workload and intensity that it generated. If you just think back to what happened in Dallas, that could have been Minnesota with a bit more planning and organization. Our experience with Lassa fever in April of 2014 taught us that we had 169 contacts for that patient that needed follow-up. So if this case had been positive, it would have resulted in a huge workload. And this case was not the end of our response. We've had 4 patients under investigation for Ebola. So each of the 4 hospitals has had the ability to test. And unfortunately, we don't have very good timing because the last case was evaluated on Christmas Eve. So clearly our Ebola response represents more than our usual infectious disease activity. And if I could use an acute care analogy, it's really a trauma response for infectious disease. Over a 2.5-month period from October through early December, we had 40 staff who were working full-time on Ebola. That included communications staff, our public health laboratory, emergency preparedness staff, our legal unit staff, as well as the staff in the Infectious Disease Division. And we currently have 3 full-time staff who are just working to monitor the 50 or so travelers that we currently have that are being monitored. Up until this point, we've had 216 people who have completed that 21-day monitoring. So that's one reason, or that is the reason why we've requested deficiency funding. The base budget that was passed last year for MDH did not anticipate this type of response. So that's a little descriptive, and I'll tell you, my family got frozen pie for Thanksgiving. So that gives you a little bit of a summary of kind of our Ebola activities in a story form. And then what I'd like to do is I'll go on to the other infectious diseases and I can answer questions.
Sure, that'd be good. Oh, I'm sorry.
Okay.
Senator Nelson, did you have a question about?
Madam Chair, I have a series of questions about Ebola, and so my question is if we want to take those now or if you want to wait until you get through the other infectious diseases. But my questions are particularly about Ebola.
Ms. Ehresmann, do you have a lot more about or would you like to finish the complete picture of infectious diseases, or do you want to stop and then go back to that?
I'm happy to do whatever is best for the committee, Madam Chair. I have Ebola, Norovirus, mumps, and some sexually transmitted diseases. But we can talk about Ebola now if you'd like.
Okay. Senator Nelson, why don't you go ahead?
Yes, thank you, Madam Chair. And thank you for the description. I can tell it was certainly on all of our minds during this time. It's a terrifically contagious disease. And I have 2 lines of questions. One has to do with the transmission, and that is the timeline, and you nailed the date I had down here too, was December 24th. So obviously looking at the data you gave us today, 47 travelers still being monitored. That means there have been 47 some possible ability to have contacted Ebola within the last 3 weeks. Is that right?
Ms. Ehresmann?
Madam Chair and Senator Nelson, yes. So we currently have 47 individuals who are under monitoring. That means that they returned from travel to the 3 Ebola-affected countries. They're currently at low but not 0 risk, and so we're monitoring them for any symptom of fever or any other change in their health status. So we anticipate that we will continue doing this monitoring until Ebola is no longer occurring in West Africa, so probably for the next year. So in terms of, when are we out of the woods, I think we have quite a ways to go before that happens.
Senator Nelson?
And Madam Chair, and so the question is, of those travelers who have come back or who are here visiting, who have been to those Ebola-affected countries, are they voluntarily quarantined, or are they out potentially infecting other Minnesotans?
Ms. Ehresmann?
Madam Chair and Senator Nelson, these individuals are currently voluntarily participating in the monitoring program. They're individuals that do not have any symptoms. And so what we know about Ebola is that if an individual does not have symptoms, they're not infectious. So these individuals are able to go about their normal activities, but they're checking in with us each day. They have to monitor their temperature twice daily, and if they would have any change in symptoms, they need to immediately isolate themselves. So yes, they're participating in society, but they're not at risk to the general public at this point. It's only if they have a change in symptoms that would be a concern. And then just to clarify, if you think back to the Dallas situation with Mr. Duncan, when we look at where there was the opportunity for transmission, it was only very late in the course of his illness, and those individuals that were providing very intense care to him. So his family members, the EMS personnel, all those folks that had been exposed to him before he was hospitalized did not develop Ebola. Just to clarify.
So just one,
Senator Nelson.
thank you, Madam Chair. Just one further follow-up to that. So of the 147 or how many, or 200 that you have monitored, how many of those are from what one might call secondary potential exposure? In other words, someone who had been in those highly infected countries were on monitoring and then developed symptoms, and then it was all of going out to that second tier. In other words, the people that they had contact with.
Ms. Ehresmann.
Madam Chair and Senator Nelson, actually all of the individuals that we're currently monitoring would be considered sort of a primary potential for exposure. So they're being monitored based on their history of travel to the 3 Ebola-affected countries, and we have not been in a position at this point where we've needed to go beyond that first ring, if you will, of monitoring, because we have not had any cases of Ebola.
Thank you, Madam Chair.
Senator Nelson.
And so what is the cost then? I know we have a total cost request or a budget request here for these unanticipated expenses regarding highly infectious diseases, but if you could determine the cost of the Ebola prevention, detection, I'd like to know what the cost is totally, and then if you have an idea on what is the cost per case, so the cost to monitor each case. I know there's an hour-long interview to start with, there's daily check-ins, that type of thing. Can you kind of give me some of those numbers or rough estimates?
Madam Chair and Senator Nelson, our overall estimates for what this was costing the agency as we anticipated moving to June of this upcoming year, we're close to $1 million. And as I mentioned, we currently have 3 full-time staff who are doing monitoring. We have staff that are on call 24/7. These individuals need to have access to someone 24/7 if they have any questions or concerns about the monitoring or their status. We have medical personnel that are on call 24/7 because obviously if they do have a change in their health status, we need to have people who are ready to respond and assist them with that. And then in addition, I guess if we think about our total response to Ebola, it included legal staff, costs with the Attorney General's office, communications staff, emergency response personnel working with the hospitals, and then our infectious disease staff. So if you'd like us to kind of put together more detailed information, we can do that, but I can't do it right on the top of my head.
I understand that. That'd be helpful.
Senator Nelson.
And then the final line of questioning is thinking about those costs then that translate down into the hospitals. So the department has incurred $1 million cost. What about those 4 designated hospitals? How are they being compensated for the costs that they've incurred, and what might those costs be? I have an idea, but I'd like to know how is the funding getting to reimburse those hospitals for those costs?
Ms. Ehresmann.
Madam Chair and Senator Nelson, at this point, the deficiency request that has been submitted was looking at the agency's costs, but I can tell you that working with the hospitals and the Hospital Association, we know that these 4 hospitals have invested a lot of money, and at this point, they're estimating probably $1 million each just to be prepared. Many of them had to do construction on their facilities to make sure that they were fitted appropriately for the infection control aspects of Ebola. So at this point, and then they obviously have ongoing costs related to training and maintaining preparedness of their staff. So at this point, we're aware of at least that. We're certainly waiting to see what federal resources will be, but it's fair to say that the hospitals have a great commitment in terms of their response, and at this point they have not received anything from the state in terms of funding.
Senator Hayden, did you have a question?
Well, I was trying to get in while Senator Nelson was
Thank you.
going down her process, because she stole a little bit of the questions that I wanted to ask, but I'm glad that they were asked. I think in addition to the hospital question that I wanted to ask, which I think that you've answered, that you haven't given them anything in your funding request, hadn't requested anything for them. So I think that we may want to think about that, because they are partners in this process, and without, I mean, it feels a little top down that we're not thinking about our providers in terms of what they might be able to need to actually do the work that we need to keep people safe and then to make people healthy if they're infected. So I haven't been involved in this conversation, but I would hope that we would think about that and have the Department of Health support that. In addition to that, I think about the issue of who gets the patient from where they are to the hospital, and I know that that's the ambulance folks, and what do they need to have retrofitted, and what kind of training do they need, and what is their cost? And I don't know if that's the system that would pay for that, or how that financing works, but maybe that's more of a statement along with that in this kind of system, right, of dealing with someone who we think potentially could be infected, from the early voluntary monitoring, because you've been in a country, to you are symptomatic and someone needs to come and get you and take you to one of the 4 designated hospitals, to making sure that the hospitals have trained staff, the equipment that is needed, and then the cost, including taking a couple of rooms, kind of offline in perpetuity to be prepared for that. So I think when we think about this, there is a lot of cost that is incurred by a lot of folks. So I would hope that as we think about this moving forward this session, that we really get your support and continue, and I'm sure we have, but I'm a little concerned that though I know that the Department of Health has incurred a lot of cost in dealing with this, that we work in tandem with the whole community of folks that have to deal with this, and ensure that we're making sure that they're compensated as well.
Commissioner Ellinger?
Madam Chair, Senator Hayden, I'm as part of being a health commissioner, I'm part of the Association of State and Territorial Health Officials, the health commissioners in all the states, and this is certainly a national issue. The costs that have been there, particularly for the hospitals that have been, or the airports that have done the screening, the hospitals that are taking these individual patients, the transportation, and there's huge costs that are engaged. So we are actively engaged with our federal partners in their requests for emergency funding, and the hospital needs are part of that conversation for sure. We recognize that there are lots of costs, there are lots of players in this, and we want to make sure that we leverage the resources as best we can to meet the needs on an ongoing basis.
Senator Benson?
Thank you, Madam Chair. And Dr. Ellinger, you started to address what my question was going to be. We have 4 designated hospitals, so obviously they're going to need some federal money, because this really is a federal issue. The Department of Health made the request based on, in your call-out box here, federally required activities, so I'm hoping we're going to turn to the feds, and because there has been some appropriation at the federal level, and so I would hope that we would put the deficiency funding, I don't want to say on hold, because your department did good work and should be made whole for that work. However, you did call out that it was federally required, and so I want to know what you're doing to put our place in line for the federal money. We, very early on, realized that because of our Liberian population, we were at a greater risk than a number of other states, and I think wisely, our Department of Public Safety, Department of Public Health said we are going to be on the front line and we're going to be ready for this. It turns out that level of response was prudent and necessary, but most other states aren't in our kind of position. States where there's a lot of interchange at airports, yes. And so I would hope that you would advocate for us strongly at the federal level instead of just leaning on taxpayers here in Minnesota.
Commissioner Ellinger?
Madam Chair, Senator Benson, actually, we are working with our federal partners. And in fact, there's a meeting tomorrow where we have just gathered all of the information from our department on all of the various areas to make that available to the people who are actually making some considerations for where the funding goes. We've certainly been working with our congressional delegation to make sure that our needs of our state, where we do have a large Liberian population, are articulated to CDC and the Assistant Secretary for Prevention at the federal level. We are actively engaged with that, with our partners and with our congressional delegation to make those needs known.
Thank you.
Ms. Ehresmann?
Madam Chair and Senator Benson, I do want to make a couple of points. One is that we have, the agency has received at this point $122,000 for monitoring. Our deficiency request was reduced by that amount because that came in. But I also want to point out that that funding is currently being split between the Department of Health, Hennepin County, and Ramsey County, which are counties that are also helping us with the monitoring. And at this point, it's completely insufficient to cover our costs. In fact, we're going to have to do a sort of a backwards approach, because if we had the staff that are full-time and charge their salaries to that exclusively right now, we wouldn't have enough money when we got to March to cover other staff that are being pulled from other programs. We're rotating through so that we aren't taking away from any one program. So we certainly are very mindful of being a good steward of state resources, but I think it's important to keep in mind at this point that our division is over 85% federally funded, and all those funds are designated for specific activities, and so we don't have a lot of flexibility. And then one last comment, and that is, we did these activities not because they were federally mandated. We did these activities because they were the right things to do to protect Minnesota from Ebola. And we are currently using the CDC recommendations and guidelines for our monitoring. But I do want to be clear that we're doing them because it's the right thing to do, not just because it's a federal activity.
Senator Benson?
Madam
Is
Chair.
it a brief question? Or brief?
Obviously, our medical community does things because they're the right thing to do. Unity Hospital took on regional responsibility because they were uniquely prepared among their regional partners to take on the Ebola response. So absolutely, I understand that. But I also understand that the federal government is putting money forward for this. And Minnesota should not take a deferential position and say, no, it's okay, we can afford to do this, and let other states off the hook. You did the work, you deserve the credit, absolutely, but the federal government can help us support this.
I think I'll have you move on to the other infectious diseases. We only have about a little over 5 minutes left, and I think it sounds like the funding to support the response at all levels, the hospital, the concerns from staff in the hospitals. We have testimony from Minnesota Nurses Association that there are still concerns about the provision of the proper equipment and training. So it seems like this is an issue that we would want to have maybe further discussion on with you to make sure that all the parties are getting a chance to express their needs. So. But I'll have you move on to the other infectious diseases, and like I say, we have about 5 minutes left. Thanks.
Thank you, Madam Chair. Well, I can tell you that just as Ebola was leveling off and we were hoping to catch our breath, influenza hit. And so we've had a crazy early widespread and severe influenza season this year. And there are two reasons for that. First is that the strain that's circulating, H3N2, whenever that's the predominant strain, we see more severe disease in the young and the elderly. And then this year's vaccine, the H3N2 strain that was included in this year's vaccine, does not match well with the circulating strain, making it less effective. And so as a result of this, we have seen a very severe season. We've had 619 schools report influenza-like illness, and the week before Christmas, we had 315 schools report outbreaks, and that's higher than we saw during the 2009-2010 pandemic. Our lab has been swamped with specimens for testing. The Monday before Christmas, they received 289 specimens to be tested, which was an all-time daily record for flu. We've had 135 long-term care facilities that are reporting outbreaks, and we've had over 1,200 hospitalizations. And our average age of hospitalization is 74, which just reinforces that this outbreak is really affecting the elderly. We've had 4 pediatric deaths thus far this year, sadly. The department continues to promote the usual messages of getting vaccinated, good hand washing, respiratory hygiene, staying home when you're sick, sleep, and good nutrition as ways to prevent and lessen transmission from flu. Then in addition to flu or influenza, we have seen our worst norovirus outbreak. And norovirus is what most people refer to as stomach flu. We don't like to use that term because it's confusing, but nonetheless, it's the most common cause of gastrointestinal illness. We've had 43 outbreaks so far this year, just in November and December. And so that means that this is, in the last 15 years, this is second only to 2006, 2007. So needless to say, the foodborne staff are very busy. I'll just mention mumps, because I can tell you when I talk to my dad, this is the most interesting thing he thinks that I've done all year, and that's because the National Hockey League has had mumps in its players. We ruled out 250 suspect cases of mumps this year. We've had 23 confirmed or probable cases, and we did have cases in members of the Minnesota Wild. And then finally, we were specifically asked for an update on our sexually transmitted disease program. And in short, I can tell you that the number of cases of disease have increased over the last decade. Chlamydia is our #1 infectious disease and has had a 65% increase between 2003 and 2013. We had 19,000 cases last year, and every single county in Minnesota had cases. So far this year, and just up through October, we've had 15,000 cases of chlamydia. Gonorrhea is on the same increase, a 14% increase over the decade, and we had over 3,000 cases of gonorrhea so far this 2014. And then primary and secondary syphilis, a 275% increase over the decade. And as of October, we had seen 515 cases of syphilis. So in summary, I'd just like to say that we're very busy in the infectious disease area, working hard to protect Minnesotans from infectious disease. As one infectious disease expert said, infectious diseases are a continuing threat. No one should think of 2014 as an aberration. This is the new normal.
Thank you. Senator Benson.
Thank you, Madam Chair. How's the avian flu season looking? A few years ago, we had quite a scare, and it's going to be approaching.
Ms. Ehresmann.
Madam Chair and Senator Benson, we're continuing to monitor for avian influenza. We are not seeing cases in the human population, but avian influenza has been identified in flocks, and in fact was identified in poultry in the United States. So we're monitoring that, we're aware of it, but we're not seeing cases of, for instance, H5N1 right now in anyone in Minnesota. So that's something that we continue to monitor, but it's not a present concern.